All right, welcome everyone to the November CHAMPS Wednesday webinar. This is Maytal, and just going to be introducing kind of the webinar today and then handing it over to our wonderful moderators. So today's Wednesday webinar is the Baby Friendly USA Onsite Assessment, and we are so lucky to have representatives from 3 different hospitals here to share their experiences and advice for us. And then after, each of them will present a bit about their experience. We'll have time for questions. So I'm going to hand it over to Laura to go over some announcements, and then we'll get started with the presentation.
Thank you, Maytal. Hi, my name is Laura Burnham. I'm one of the CHAMPS project managers and a hospital coach, and I will be moderating this webinar along with my colleague Jennifer Ustinov. She's really been coaching a lot of the already designated hospitals. So we're excited to be with you all today. Okay, so just a few announcements before we get into our presentations. There is an upcoming CHAMPS training on Monday, December 2nd. It's a CHAMPS clinical competency training at St. Dominic's Hospital in Jackson, Mississippi. And there's going to be 2 sessions. So there's a morning session and an afternoon session. And so, any CHAMPS hospitals are welcome to register to attend, and CHAMPS community partners can attend as well. And you can see the registration links here, but you can also find them on our website. We also have one more upcoming Wednesday webinar in this Wednesday webinar series. It's going to be on December 11th, and it will be on the interprofessional breastfeeding education that CHAMPS is helping to develop with UMMC. And Dr. Mearwood will be presenting that webinar along with UMMC faculty. And then we just want to put a plug in for our Spring 2020 series. We are developing that series now, so in the future just look out for some announcements on those webinars. And then I just want to remind everybody to, if you're not speaking as one of the speakers, please place your phone on mute so we don't hear all the background sound. And then also, if you do have to take another call, please do not place us on hold, or else everyone will be hearing your lovely hold music. Okay, so without further ado, I'm going to introduce Lindsay Robertson. She's from Anderson Regional Medical Center, and Lindsay's going to share about their the whole process for their on-site assessment and designation, Baby Friendly.
Hey, how are you? Okay.
Hi.
Let's see. Sorry, I haven't fighting a cold, so if I get into a coughing fit, I apologize. Let's see. Okay, so we here at Anderson, we started our journey about 4 or 5 years ago in Baby Friendly, so it's been a long journey. Just to give a little background information, we have 3 separate units. We are not LDRPs. We have a separate labor and delivery, postpartum, and nursery unit, and the nursery nurses are also take turns working in the NICU, so they both work in that unit as well. We have a level 3 NICU. We average about 1,200 deliveries a year. That was last year. This year is probably going to be closer to 1,000 or 1,100. Our census is a little low. We have 10 beds in our labor and delivery, 22-bed postpartum unit. We also have a triage overflow unit we can use if we need to. We have, at the time of our Onsite, we had 3 neonatologists, and now we only have 2. And we have 7 OBGYNs and 4 midwives. We have 69 RNs and 2 IBCLCs. 2 of us are CLCs, but full-time IBCLCs are 2. We have 1 affiliated prenatal clinic, and it's only 1, but that clinic does 40% of our deliveries. They also have a contract with the Choctaw population in the hospital, so that tribe comes down to that clinic towards the last trimester, probably their last 2 or 3 visits, and we'll see that provider. So that was a little challenging for us to get that education in quickly because we couldn't hold the Choctaw clinic liable, or we had no grounds to make them do the education. So like I said, we really started with CHAMPS in 2015, but we didn't actually enter the discovery phase with Baby Friendly until 2016. And then about every fall, we fell into the next phase, and we stayed on track. And we had our Onsite assessment on August 1st and 2nd. It was a Thursday and a Friday, and we were called back and got awarded on September 11th. So right at 6 weeks. They told us it would be 8 to 10. So I knew it was going to be a little bit of a waiting time, but we were excited to hear. Some of the things that we struggle with, especially from the beginning, our doctors are not the OBGYNs, but our neonatology group. We have just neonatologists. We don't have pediatricians that see our well baby, and I feel like that is a struggle for us because they kind of just had that sick baby mindset, and it was a lot harder for them to kind of let go and let our baby stay on the chest and not be assessed first, on the warmer, or and they still, up until, even on our own site assessment, they refused to round in the room. So our 1 hour had to be taken up with our neonatologists doing their assessments each day. So that was a struggle for us as well. Each nurse had to document the exact time that baby was taken out of the room and the exact time it was brought in, and they had to make sure those rounds were less than an hour. So all of our hearing screens, all that stuff, it was done at the bedside in order to keep us compliant in that area. We also, our neonatology group, they are not pro-baby friendly. For an example, our hospital competitor across the street, they serve both hospitals. They serve ours and theirs, and they, y'all may have seen the well-known family-friendly advertisement commercial that they are not on the baby-friendly pathway. So you have two hospitals, same doctors, doing completely opposite things. So that was definitely a struggle for us. That mindset towards baby-friendly kind of was put off onto the staff as well. So when their doctors are telling them one thing, then it's kind of hard to sometimes get staff buy-in to get on the right path. But thankfully, we had a strong administration, and they supported us 100%. They were behind us. They did unit rounds, just informing staff that this is what we're doing. You can either get on board or get off. And that kind of, said firm, thing that's backing us with all of this, they were able to keep our staff on track and kind of help us meet our goals. And we finally got there. Let's see. Like I said, our Onsite was on the 1st and 2nd. The main thing really is your prep work. All your notebooks and everything need to be organized, all of your policies, everything, all your staff education. You want that. That's one thing you can control. You can't control everything your staff says in their survey. You can't control everything that the patients say, but that's one thing that you can control. So make sure that your side of it is completely done and organized. I made rosters. I had 2 for the surveyors and 2 for the runners. Make sure you have a runner for each of your surveyors. So that person should be dedicated to them. Do not leave their side. There'll be times when they'll say, hey, we're just going to, have a sit-down time and talk in the conference, and we literally just sit outside the door in case that they exited and wanted to go do a survey. The very beginning was our opening roundtable meeting. We had our CEO, our CNO, our nurse managers. We had a WIC representative. We had our purchasing department there, our IBCLCs, and our key core team members for that. The majority of the questions there, they were directed towards me as the team lead. Some of them went to the CEO, but most of them were just yes or no questions. It really reminded me of your RAI or your checkoff tools and stuff. Do you have a policy for this? Do you have a policy for skin to skin? Just basic questions. So as long as you know that RAI stuff pretty well, you'll be fine with that. Let's see. I did went ahead and had my providers scheduled for right after that opening session. That way I could go ahead and be in control of that, have those, and they allow you to go ahead and schedule your providers. So that for us was a huge benefit because we had control over who they got to talk to. So I had those lined up right at, I believe it was like 9 o'clock, and so they were waiting outside the door. The two of the providers at the clinic that they were going to visit, they did those there, so they didn't have to come up here for that. But the other three, we had them here in waiting. We also provided them some recommendations for meals and stuff to do while they were here. You can't give them food, so don't plan like a big breakfast or a lunch or anything like that. But we did provide bottled waters and just hard candy for them. So one thing we didn't think about until like the week before is like a visitor badge. If they're going to be in and out talking to your patients, make sure to get them a visitor badge, something that they look official and the patients don't get concerned. Let's see. Yeah, they just went through the main yes or no questions. After that, right before we left the opening meeting, they had us roll a dice, and I think we drew like 5 or 6. And they literally went down our roster for staff that were going to be there that day for night shift and day shift. So it's only the night shift and the day shift for that very first day. I'm guessing if you didn't have enough staff, if you aren't a big hospital, they would maybe roll over to the second day. But for us, we had plenty, and they didn't have to do that. So they literally counted down 1, 2, 3, 4, 5, 6, and circled that person's name and went down until they had, I believe it's 10. It's been a little while, but I think it's 10. And they wanted an even number of night shift and day shift as well. So one of the surveyors started the provider interviews, and then myself and the second surveyor, we went over to the prenatal clinic. And for that prenatal clinic, they did awesome that day. They had their patients scheduled for 15-minute increments, and it went so smooth. As soon as one patient was finished, I had the next one waiting and ready to hand them off. That kind of allowed me, so while one person was in there being interviewed, the other one I had right beside me, and I was kind of just not prepping them, but just, making sure they knew the type of questions they may be asked. And then if there was any free time in between them or any time slot that there wasn't a patient there, that's when I went ahead and brought in the provider for them to do those audits. We did provide patients with some little refreshments, just little muffins and waters and stuff. So that just a little thank you for doing that, for doing the survey for us while they were there at the prenatal clinic. Let's see. Then they came back over here, and they both started on the postpartum interviews and NICU interviews. Thankfully, we ended up unexpectedly with a larger census than what we thought on the floor. So I think we had 10 postpartum moms. 2 of them babies ended up in the NICU, so they were able to go ahead and use those for the NICU moms. One thing is that they can't use the same mom for 2 circumstances. So, for instance, like one mom had a C-section, but her baby ended up in the NICU. So she only counted for that NICU interview. She did not count for a C-section and for a NICU interview. One mom was up there visiting her baby. So if you know of a mom, or if you know a baby that's going to be in your NICU that's maybe been there for a few weeks and is not going home, go ahead and talk to that mom and see about when she's going to come see her baby, because they will prefer to go ahead and do that in person and not have to call her. So that helped, and we were able to give that mom a heads up. I went ahead and called all the moms that I thought, I made a large roster. I would just be extra cautious, and if for some reason the first 10 moms don't answer the phone, go ahead and give them another 10 moms to call. So you may be going back in your list, but the odds of them getting that far are slim. But you would rather already have them on there than have to go back and scramble the day of or the second day to try to find more moms to call. So go ahead and just make you an extra large roster for both your prenatal clinic and your postpartum. Thankfully, all of our prenatal patients were done in the clinic, and they didn't have to call anybody. But our postpartum moms, they did have to call, I think, 4 C-section mamas and then maybe 6, vaginal deliveries. But I had already called those moms the day before or a couple of days before, gave them a heads up, and knew they would be getting a call. I even started probably about a month before they came. I started telling every mom. I started auditing almost every single mom, and I went ahead and told them, on this day, you're probably going to get a call from our number. You may not have that number in your phone, and just go ahead and answer it because it's going to be us doing a survey. So that way, moms just knew ahead of time you're going to get a 553 number and to answer the phone. So make sure, just like I said, over-prepare your rosters. That's like the biggest advice I can give for that. Purchasing. So after they did some surveys and did most of the postpartum calls, they did our purchasing probably about 1 o'clock that first day. It's very thorough. So we had a little hiccup here, but thankfully we were able to get through it. Our purchasing agent, I'm not sure where we went wrong here, but they were under the impression they just needed 3 receipts and invoices for each product. But those invoices and receipts have to be for different months. So you can't, if our survey was in August, for example, she had 2 of the receipts and proofs of purchasing. If we purchased that product twice in 1 month, she had like 2 Junes instead of a May, June, and July. So just make sure that you have, 3 separate months. And it doesn't have to be consecutive months because you may not have purchased that product each month. It may be a January receipt and then a March receipt and then a June receipt. And as long as you have purchases in 3 separate months, then that's good. But it has to be within a year. And it just has to be 3 separate months. And they go through each item. They're going to go through each bottle. They're going to go through each nipple. They're going to go through each type of formula you purchase. So just be prepared for that's a stressful part of the survey. But as long as you're organized and got it in order, you'll breeze through it. Go ahead and ask your night shift girls to come in early. We asked ours to come in at about 6 o'clock. That allowed them to go ahead and do their interview before shift change and report, and then the providers were able to get on out of here that night. Let's see. Okay, on day 2, since we were able to get all of our surveys done the first day, they actually let us come in and start later that day. I think we were started around 9 o'clock. The second day, that's when they went around and checked all of our poster locations and our formula storage locations and make sure that it's behind closed doors and not inside of any patients, if they're coming through to see their baby in the NICU or whatever it may be, wherever you keep your formula, just make sure it's not in view for anyone to see. Let's see, that second day, one surveyor got to witness a vaginal delivery, so we got really lucky with that. She also watched that nurse get that mom started with skin to skin and assisted that mom with her first breastfeed. The other surveyor sat down with me, and we went through all the prenatal education, all the prenatal, like the brochures, our class handouts for like our breastfeeding class and everything, and our postpartum education. One thing, go through, if you hand out a booklet or a pamphlet, make sure you go through there and there's nothing, a nipple, a bottle, even if it's a pump. I know it sounds crazy, but even if it's a bottle that goes with a pump, a breast pump, if there's a picture of it, cover up the nipple. The booklet we have, we knew that there was an issue on a couple of pages, and we just put little smiley face stickers on top of it, and that was perfect, and they were fine with that. They did review all the staff education and logs, so anybody that was surveyed, any staff that was surveyed, they went and checked for that person's education. So anybody you have on staff for those 2 days that will be here, make sure that their education is in that book and exactly what they need, because those are the people that they're going to look for if they get surveyed that day. Let's see. They reviewed all of our policies and make sure that any coinciding policies like hypoglycemia and stuff were in there, and that they met standards and didn't have anything that contraindicated the baby-friendly stuff. The last couple of hours, we left the room, and the surveyors spent their time typing up their report for baby-friendly. They'll tell you over and over again, they're just here to survey. They don't make decisions. They are just there to form a report, and they present it to the board. And then they left around noon and told us to plan our party. So I was excited when right before they left. I said, "So 8 to 10 weeks, right? And we'll find out that we passed." And she just smiled and said, "Playing your party." So I felt good about it. Of course, I didn't take that too seriously, but I felt good about it because they're the ones who actually talk to patients. They know what they said. And then the results, like I said, took right at 6 weeks, and they did not have any recommendations or anything for us, so we didn't have to go back and fix anything before they awarded us. So we got lucky. I definitely will say that we had the best survey that I think we could have had. It went smoother than the only thing that I would have tweaked would have been the purchasing part of it. Other than that, it was definitely prayers answered for sure. I think that's it. If y'all have any questions.
Awesome. Yeah. Does anyone have?
I forgot the next step. I was going to say our next step thing is we're going to, of course, advertise. We have a commercial in the works, and then we just had a big party about last week. They served us steak and lots of good food to celebrate, and then some things we're going to work on is we're going to try to aim to do our skin-to-skin in the OR and not wait to recovery. That's in our future. We're definitely going to keep track of our monthly data. And then I've already set up, we're going to do our annual skills fair in January and in June. That way we don't ever let that lapse, because each year you have to at least do 1 hour competency for your staff in order to stay on track. That's part of Baby Friendly's requirements. So it's easy to, after you get the word that you've passed, just kind of like, okay, we're done, and not keep up with everything. And that's one thing that we're trying to avoid.
Great. Thank you, Lindsay. I think we have time for like a quick question, and then if people have other questions, they can keep them till the end. I just want to make sure we have time for all of our presenters to share. I also want to mention at this point that there is a chat box. So if you look at the bottom of your screen, one of the little icons is the chat icon. So if you have a question, you can always type it into that chat box at any time, and we will keep track of those questions and ask them at the end. But first off, does anyone have like a quick question for Lindsay right now? All right. Well, why don't we move on to our next presenter. Let's see. Natal, are you able to?
Hey, Laura, it's Amy Cross, and I'm actually here. I thought I was going to be delayed, but I can go now or I can go third, whichever.
I think, Amy, that we did move your slides last, but I'm glad you're here. Thanks for letting us know.
Okay, perfect.
Awesome.
So, Kim, did you get the presenter privileges? Are you able to?
I did. Here we go.
Wonderful.
Yes. So, my name is Kim. Are you ready for me to start?
Yeah, Kim. So if you can start. Kim is from Southwest Mississippi Regional Medical Center. So she's going to be talking to us about their journey to their on-site assessment.
So, hi, welcome everyone. My name is Kim Pace, and I have with me Angela Parker, who is our house CLC, and she's going to be with me, and we're going to both kind of be talking back and forth during this webinar. So we opened our LDRP suites here in Macomb in 1993. Since then, we've delivered over 20,000 babies. In December, we marked our 26th year just providing single-room maternity care. So that was one thing I wanted to mention to you guys. We have 9 LDRP suites, so we don't have separate labor and delivery and recovery and all that stuff. So we do it all in one room, and we have 9 rooms. We have 29 registered nurses that function on our unit, and only 8 of those are actually dual-trained nursery NICU nurses versus labor and delivery nurses. So we don't have the luxury of having all of ours cross-trained. So anyway, we have a level 2 NICU. We have 4 pediatricians. We do not have any neonatologists actually on our staff. We have 4 obstetricians, And now we have 2 affiliated clinics. At the time of our assessment, we only had 1 affiliated clinic, but we actually have 2 at this point. All right. So our Harley trained perinatal staff work together as a team to provide the best care for our mother and baby couplets. So our journey took place over the last 3 years. We started with discovery in January of 2016, and as you can see, just progressed through. We went slowly. We probably could have gone a little faster through these phases, but we really wanted to take our time with each one of them and make sure that we had everything together and so that we would be ready for our on-site assessment. So our on-site assessment, as you can see, was October the 21st and the 22nd. And we just finished that, and we have been just taking a deep breath and actually just getting ourselves together to get ready for the next step. Angela, do you want to intervene anything here? Okay, I guess not. Okay, so our next thing is our assessors were Peggy. She was a retired nurse from Chicago, and Diane was also another retired nurse from New Jersey. So in preparation for our on-site, the most helpful things to us, because we didn't have a whole lot of people, there was not a whole lot of people going through their on-site assessment and all that when we were kind of prepping for ours. I think we've all kind of done this at the same time. So the CHAMPS was like a great help with us and keeping us going. Every time we had questions, they always had great answers for us. The mock assessment was great. That is a wonderful thing to help you get ready and prepared for your on-site assessment. It is literally almost exactly like how it's going to happen when they come. And, of course, contact Baby Friendly with questions if you need to. And if you don't have monthly task force meetings at your hospital, I would suggest that you do that. We did not involve every single person that we probably should have in the very beginning. We didn't bring purchasing into our task force meetings early on, and that's probably a mistake that we made early on, because as we got to the end, that's kind of where our glitches were happening, and I think she mentioned the same thing with the purchasing department. And I think if they had better understanding of what we were needing and what we were asking them for and what they're supposed to be keeping up with, if they kind of had a better understanding early on, I really feel like any little glitches we had along the way probably could have been solved. Also in preparation is making sure you're doing those audit tools, keeping the nurses and healthcare providers and patients with those interview questions. And most importantly is those patient interviews. Angela did so many of those patient interviews, and trying to keep them, up to date on what maybe what the assessors could be asking them, making sure we had all the information that we needed. Very also important is to make sure you're contacting your patients prior to your on-site for recall. We called those patients, Angela called those patients, I didn't call very many of them, to make sure that they were prepared for the phone calls. She called them like a month in advance, then she called them a week in advance, then a day or two in advance. There's not enough time to call them all as like you'd like to, but the more you can contact these people to prep them for the call, the better. We also did, as the other lady said, is letting them know that we were going to be calling them the day of our assessment, and we had also a very large list of patients for all the calls, and we had issues with patients not answering the phone, even though they were told numerous times that they were going to be called. They still, some of them did not answer the phone. So, and then our assessors they like to do a lot of things on their own, that we tried to intervene and like help them do some things, and they'll be like, oh no, we got it. So they didn't let us help them a lot. And so I think we had some issues with some like long distance numbers, and the way our hospital has a code like to get an outside line. Some of these patients they couldn't reach because they were dialing the access code wrong out of our system, but then they didn't tell us to the very end of the day that they weren't able to get in touch with some of these patients, and it was all just a phone glitch that if they would have kind of told us that earlier in the day, we could have helped them, and maybe they could have got in touch with a few more. But like I said, they were very, I don't know, they were very loners, I guess to say. They didn't really want a lot of input. I mean, they would come to us if they had questions about certain things, but for the most part, they wanted to look at all the binders alone. They didn't want anybody with them unless, you know, it was at our clinics and stuff like that. But other than that, we just kept going to them and said, "Are you sure you don't want one of us to help you or something?" And they would be like, "No, we got it. We have what we need." Anyway, so that's just some kind of little tools there. All right, so also I'm going to go through some of these things. I'm just going to talk about when I go through our agenda. So I'm going to just kind of skip this one. So the very first day, the very first morning when they arrived, we had 18 people in our morning meeting. And also, just like the other lady said, we were expecting questions to senior administration and all that, and so they really did not do that. They really just ask questions from that tool, from that policy checkoff tool. And literally, probably, just like she said, almost all of the questions that they asked were directed toward Angela or myself, who were the leads here in the hospital. And so everybody else is kind of sitting over there shaking their heads. And I had a couple of charge nurses that I had asked to come to that morning meeting, and so I had to kind of bump them a couple of times for them to speak up, because I felt like Angela and I were the only two answering the questions in the room, because every time they would ask a question, they would look at me or they would look at her, and I was like, the charge nurses really need to speak up and like talk, because I think they kind of wanted to hear what they had to say more than they expected Angela and I to know the answers to these questions. I think they wanted to hear from them as well. But they did not even ask one single question to our senior level administrators at all. So immediately after that, like literally they just shot off and wanted to get started. So we had several physician interviews scheduled immediately after that. And of course, just like I don't want to repeat every single thing that the lady before me stated, but of course you have to have your rosters and you have to have your runners, making sure you have one person assigned to each of the assessors, and keeping your agenda and staying on time and telling them where they need to go here or need to go there. So they started seeing physicians and doing some nurse interviews. We also had a list of nurses that we had already talked with and everything, and so but like she said also, that day I had already pre-scheduled and had all the nurses there that we wanted to interview, but there was one nurse there that wasn't on the list to be interviewed, and it was like it didn't matter if she was on the list or not. They really wanted to talk to every single nurse that was there that day, whether they were on the list or not, and we were sort of kind of under the impression that we would get to choose only the nurses that they spoke with. And for the most part, that was true. But I felt like if we would have had more nurses there that weren't on that list, it wouldn't have mattered what we had on the list. They were going to interview whoever was there. So just be very careful. If there's some nurses that you really don't want to be ones that are interviewed, I really wouldn't even have them there the day of your on-site assessment. Physicians either. I wouldn't have anybody around that you do not want them to talk to, because we all have those people, I think. So anyway, so after she was doing some of those interviews, the other lady and I went over to our one affiliated clinic. And so we had all the patients already pre-lined up as far as appointments, kind of right behind each other. And so they went quickly through those interviews, and then there was really no downtime. And then at the end, they interviewed our physician, one of the physicians that has the affiliated clinic. So they did his interview, and then we came back, and we didn't actually have but one postpartum patient on the floor, I think, when they came. They came on a Monday and a Tuesday, so we were kind of slow from the weekend. So anyway, and they did interview her, but then the rest of the patient interviews were by phone. So that's why I would also say, like she did, we had a list of 20 for vaginal deliveries for them to speak to, and when they originally went down the list, only 6 of the 20 answered the phone on the first time. So, and then, as the day went on, they more and more would answer, but I would definitely say have way more than the required amount, at least double or more as options for them to call. And so, I think I went, did I go too far? Yeah. Yeah. So, of course, on your roster, we had 10 nursing staff, and it was also, like she said, divided up into day and night shift. And we had our night shift nurses scheduled to come in a little early, starting around 5 or 5:30. And as you see how the day is progressing, you can have those staff coming in a little early or a little later, depending on kind of how the day has gone. They interviewed our providers, all of our providers but one, on the very first day, so all those got done. We were able to get in touch with all of the moms except for 2 vaginal deliveries on the very first day. And then the next day, first thing that morning, they were able to get 2 more, so we got those done very quickly. We did not have 5 NICUs. Because we don't really have that many sick babies, which is a really good thing, but they did not have 5 NICU moms to talk to, so they only talked to 2. But they also, and she said that was adequate, so they just took that. So one thing, there was a couple of things that I wouldn't say really call a glitch, but 2 things that they kind of had questions about. So one of them was a nurse who they did an interview with, who received her 15 hours or her total 20 hours of baby-friendly training at another facility while she was still employed. She was PRN there and PRN with me. So I just took her papers and things she brought to me from Ochsner. I think Ochsner in Baton Rouge is actually where she was employed, and they did the COFECTIV training. And so I did not have, all I had was her certificates and proof of her 5 hours of hands-on training, but I did not have a curriculum from COFECTIV stating how she met the criteria, the curriculum of all the training, whatever. And so I was scrambling the next morning trying to get someone from COFECTIV or somebody from Baton Rouge, from Ochsner, Baton Rouge, to send me that information really quick so I could have that to show them each step in the curriculum, how it satisfied the training. And so we were able to get that really quick. So if there's someone who's received training at another facility and they're going to be one of the ones that they interview, make sure that you have that and have that curriculum available for them to look at. And the other thing was when they were doing our assessment and going through looking at where we keep our formula and our nipples and bottles and those sorts of things, we were receiving some bags from Pampers, which we thought that Pampers obviously is not an infant feeding product. They don't make formula or nipples or pacifiers or anything like that. Plus, we are actually purchasing our Pampers. We're not getting those for free anyway. So we thought that it would not hurt anything to give these patients a little bag that had coupons for, it was non-infant feeding related things, and it was like sometimes it was a breast pad, sometimes it was toothpaste, sometimes it was lotion or something like that in the bag, but never in the last probably 2 or 3 years we've been receiving these bags was it ever anything related to an infant feeding product. Well, of course, that day we had just got the week before that we had gotten a new box of bags, and we did not check that particular box. And so we just put them on the shelf because they looked exactly like the other. So when she was there, she asked, could she look at our bags? And we were like, certainly. There's not anything in there. You're more than welcome to look. So she opened the first one, and, of course, there was nothing in there, nothing infant feeding related. And then she opened the second one, and she went through each piece of paper like with a fine-tooth comb. And inside of it was an advertisement for a sticker company, and on that had a picture of a baby with a pacifier in its mouth on one side, and then on the other side was a bottle that was labeled with one of their stickers with a nipple, a bottle and a nipple. And so when we saw that, we were like sick. just like, this has never happened. And so the assessor was really nice. She was like, yeah, this really makes you sick, doesn't it? And we were like, yes, ma'am, it really does make us sick, because we thought we had done so good of making sure we had everything in order. But that was one little glitch. But they acted like it really wasn't that big of a deal, so we just kind of moved on. So anyway, one thing that our assessors told us was that we were very organized. We felt like we had kind of everything in order, and we felt like since they never really asked for any help from us, that they found everything. You know, it was all right there in front of them, and they never really had to ask us to help them find anything. So we thought that was a good thing. Do you have anything to interject, Angela, about our on-site? Okay. One more thing I was going to say real quick was that when they left, they didn't really say anything. You know, they're not supposed to tell you, like, you know, how they thought you did or whatever, and they didn't, but they did make reference to, well, when you redesignate in 5 years, you know, you're going to need to do this, 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 and this. So I don't know if that's a good thing. we kind of took it as a good thing. But like I say, we're next Monday will be a month. It will be 4 weeks since we had our on-site assessment, and of course we haven't heard anything yet. But we are hoping to hear something soon from that. So our next steps going forward are we're going to take our task force meetings down to just twice a month instead of every month. Every other month instead of every month. We're going to get closely more related with our affiliated prenatal clinics to do some better training and some better prenatal education with our now new prenatal clinic and with WIC. Pediatric referrals to offer immediate help to discharged breastfeeding culprits, continue our monthly data collection. Another thing we want to really get deeper into is safe sleep implementation, which we've touched on that some, but not as deep as we want to. And then try to get some more breastfeeding support groups going in our community to help with the sustainability of breastfeeding once they leave the hospital. Because we talked about this in our task force meeting just this week, that it's one thing for the hospital, you know, to do it in the hospital. They have all the support they need in the world in the hospital, and when we're discharging, we're very supportive, but it's just when they get home is when they really need some, you know, even though we give them our phone numbers and we tell them to call, it's almost like we need to be initiating the reaching out to the patients to try to help them, because sometimes it's just so easy for them to say, just forget it, I'm just going to give the baby a bottle, especially if their family's not very supportive. So I would love to try to come up with some sort of support, even if it's just a phone call back to the patient to make sure that that's done within a day or two of discharge. So that's just something that we're working on, hopefully, for the future. And that's it.
Great. Thank you. Thanks, Kim. Are there any kind of questions for the team at Southwest? Have there been any questions in the – oh, yeah, go ahead.
Oh, yeah. Hi, this is Jennifer Ustinov, and I, first of all, thank you both to Lindsay and Kim, and those are great tips. It's so great to get that retrospective. We had one question in the chat about engagement of physicians, and this seems to always be a theme. Sometimes it's nurses, though, that we have to get a few of them on board, too. So I was wondering if from Kim or from Lindsay, were there any things that you found were very key to have the physician buy-in and participation and cooperation?
This is Lindsay. I would definitely say administration. They're the key to getting it done. For the longest time, even our OBGYNs who supported it, but were just, you know, taking their pretty little time to do their education. As soon as we got our chief of staff provider on board, and he went to those doctors personally and called their nurse managers and stuff at their clinics, it was done very quickly after that. And even after the years of emails and notes I put in their boxes and all that, it didn't do it. It wasn't until someone above them who kind of had authority a little bit put that into place to get things rolling.
And this is Kim. I'm just going to ditto exactly what she said. It was the same exact issue with us until we got some senior level administrators on board with kind of giving them a little boost. Once we did that, it was no problem at all. But another thing is just trying to get, we got 2 of our physicians, one OBGYN and one pediatrician, that were part of our task force and sort of made them champions from the get-go. And then, of course, we were lucky that our OBGYN was actually chief of OB, and he was actually the chief medical officer of our hospital. So that also helped.
That's great. Thanks, ladies. There's one other question about if you've had any discussions so far about putting in the budget the annual cost requirements for maintaining baby-friendly certification. Have either of you had any conversations with your department heads or administration about that?
I haven't, no.
I haven't either. Our administration was the one pushing us to become baby-friendly, so they better not give us any trouble about paying for it after we've received it.
Great.
Yeah, so I mean, as I say, it wasn't our idea; it was theirs from the beginning, and now we love it, obviously. But yeah, so we haven't had that issue yet. Now, they definitely had to kind of go to the board as to why it's important. So maybe, just reiterating the benefits, why we're doing this, why the state of Mississippi is doing this, and the importance of it. I feel like I don't think anyone will back you if you show that if this is evidence-based practice, then this is best for our community.
That's a great point, Lindsay. And I think, in a capital budget, it isn't very much money, but then sometimes they're looking for any opportunity to cut corners. And so I always like to talk about this early and soon and draw it back to the fact that this really holds us accountable and to the fire for evidence-based practice. And it really has been an impetus for all of you to really transform the care that you've been giving and really bring it up to that level for some of this criteria that is evidence-based. So I think really going back kind of, to the mission of delivering evidence-based care and high-quality care, and this really does help us to keep our eye on that ball and not let things slip back. Thanks, ladies.
All right. So Amy Cross is our last presenter today, and she's from Mississippi Baptist Medical Center. So without further ado, I will hand things over to you, Amy.
Okay, thank you. Well, there's really not much else to say because those were so great, and they hit everything, especially with our survey as well. Let's see, how do I move slides?
On the
how
left
do I go
side
forward?
of the screen, there's a little 26, and you should be able to press down, the down arrow. If not, I can advance the slides for you.
Okay, I don't see the 26.
Okay, I can advance the slides.
Okay, thanks. So we have 8 labor beds. We do have an OB-ED and an OB hospitalist on site 24/7. We have a 19-bed postpartum unit. We do couplet care, and we average around 180 deliveries per month. Here at Baptist in the Jackson area, our neonatologists see both the well babies and the NICU babies. We do not have pediatricians that see the well babies. We do have lactation nurses available. They are here Sunday to Sunday, and they are here from 7A to 7P. And then the nurses are an extension of the lactation when they aren't here. Our rooming in rate is 95% on average each month. and that's just a little history. For on-site preparation, our team met weekly for the 3 weeks leading up to the survey. They came on October 2nd and 3rd. Checklists were created for each area and reviewed at each meeting to see what still needed to be accomplished. We did assign escorts for each surveyor. It was somebody that knew how to navigate the chart, as well as the postpartum area. So it was my unit educator was one, and then the head of our unit practice council was the other. So one was assigned to each, and they did not leave their side the entire time, and we stood outside of the doors as well when they were in with patients, doing patient audits or even staff audits or interviews. We stayed outside the door just in case they needed us for anything. Staff nurses were scheduled that day for the evaluation. They were prepped and reviewed on possible questions and answers. And then the survey days. So we did meet with administration in the conference room. There was a quick review of the schedule for the survey. The same questions were asked. We had a room full of people, so everybody was able to answer or pitch in if needed. Let's see, they were escorted to the mother-baby unit where we had 2 rooms designated for their use for the interviews. We had a phone set up in there so that they had their room for the phone interviews if needed. So the surveyors, upon arrival to the mother-baby unit, she requested a roster of all nursing staff, not just the ones that were scheduled on our 2 days. She informed me that that nurses would be selected from the entire staff, which made us sweat because we were not prepared for that. And we told her, we were prepared for the ones that were here. We have our schedule 6 to 8 weeks put out in advance. So the ones that are not here, I don't know if they're chosen, I don't know if I can get them to come in. So we rolled the dice, and she ended up choosing from the roster for the 2 days, day and night. And I think we only did staff interviews the first day. We had 10. It was no problem between us and labor and delivery to get people. But that did make us nervous. So I don't know where that came from. I don't know if anybody else has had that experience. But
Can I just interject? This is Laura from CHAMPS. We did check with, so we heard about that, and we did check with Baby Friendly USA, and that was an error on their part. So that's not, they should have just, they scared you for no good reason. They really should have just requested the list of staff that were working those 2 days and chosen the staff that they were going to interview from the staff rosters for those days. So I'm not sure what those why there was confusion with those assessors, but we let Baby Friendly know that happened, and we let them know that it was with your hospital, so they're gonna talk to those specific assessors and make sure that for whoever gets them next time, they don't do that.
Yeah. Well, she told me, she said normally what happens is when we announce that we're coming, every staff member knows, and I was like, oh well. Why our schedule was already done 8 weeks, at least weeks before we even had the dates. So anyway, we got that worked out, but we did sweat. I mean, we were sweating.
Yeah, I'm sorry that.
No, that's okay. That's okay. It ended up working out. So, so the surveyor was also concerned about the number of OBs that were on our list to be interviewed because we don't have pediatricians, so they wanted 3 OBs and 2 pediatricians. Well, we have 1 neonatologist here for the whole week, and so she was adamant about us getting another neonatologist in here. And it just so happened that our chief his wife had hurt her knee, so he missed his flight by 1 day. So we were able to talk him into coming because she was not letting up. But we didn't have the pediatricians. We explained that. We tried a nurse practitioner for the neonatologist, and we tried another OB. She said we were too OB heavy. So thank goodness that it worked in our favor that our chief of neonatology could actually come in when he did. So many of the inpatients actually did not want to be interviewed, and several of them requested discharge at 24 hours not to have to talk to the surveyors, and I'm not sure why that happened, but and then one of our surveyors, she did not like the phone interviews, and I understand that because, I mean, if we can get them done in person, it's so much easier. Like, let's get them done. It's all right here, and it's real time. So our facility highly recommends having a list of 20 vaginal deliveries and 10 C-sections for the phone interviews. So just like the other two presentations, I know that they say 10 and 5 or 10 and 10, but having an additional list in case is very helpful. Because we did have to go back and pull some more names, especially since we didn't have the ones here would not speak. But she did try and call the ones that had been discharged, and one of them hung up on her. So they truly, for some reason, did not want to speak. I don't know. I highly recommend organizing your education binder with all education per name using the ABC tabs. So we had 3 separate educational sheets. And what I had done is say under Amy Cross, I had all 3 that under there. And that's what they look at. They want the name and they want to see those 3 sheets right there, or whatever whatever you have to show your education was completed. Instead of doing it for this class, and this class, just put all 3 under the ABC tabs per staff member. The finance piece, we were very prepared for this. We did not have any glitches, had no problem. We had the order, we had the transaction, and then we had the cancel check for every single item that we ordered. The only thing I would have done different had I known is I would have organized them in categories because they want 3 receipts per category. So, like, if I had known, I would have had all the pacifier receipts together, all of that information. I would have had all the Similac together. I would have said that we didn't have to go through each one. They would have already been organized for them. But that went beautifully. There were no problems. There were some chart checks. They were sporadic. They were only to back up what the patient said or disprove what the patient said. We did have an NI mom tell the surveyor over the phone that she didn't have a pump set up for at least 48 hours, and so they went to the chart, and in fact it was started within, she said 2 days over the phone, but it was started within 2 hours of delivery. So that worked to our favor that we had the chart. Are you able? Oh, there we go. So ours is short and sweet, but like I said, everything was said. It went the same way. The flow was the same with everybody, with the other 2. So our future goals are getting the phone call that say we succeeded, and then our educational growth opportunities to continue that. And we would like to increase our online educational opportunities for patients before, during, and after delivery. So it's been right at 6 weeks, so we're crossing our fingers.
Great. Well, thank you all. So I know we're kind of right up on the hour mark, but we want to give anybody who wants to stay on the line and ask some questions. We'll stay on as well. And then Jennifer, if you have any questions in the question box, let us know.
Thank you so much.
Thank you. Open up to questions from the group.
We didn't have any other questions that came in on the chat yet.
Yeah, anybody on the phone who wanted to ask a question?
I had a quick question.
Yes.
Can you hear me? I'm in Texas, and we're at an academic medical center. And so I'm thinking, like, on any given day, we just have one attending pediatrician, and then we have residents. Are the residents also included, or do they only want to talk to faculty and attending? Do you know?
So that's a great question. And we have, I think the UMMC is the Academic Medical Center in Mississippi. And I believe we'll have to, I'm not sure. Jennifer, do you remember with UMMC?
Yes, I can answer that. When you have a residency program and you have residents going into the rooms, and they're sometimes in there more than the attendings are. And so it's pretty important that they have a good working knowledge, just like the physicians. And also, I think, I work at an academic center in Vermont, and I really think that it's also our responsibility to give those residents that information. So if you can find some time in the residency program where they can go through those 3 hours, then they'll have it for wherever they go.
Right.
Residency program. Yeah.
We currently have them do the 3 hours. All of them are certified, and we even do ongoing continuing education with them. I'm just wondering for the roster. I'm just literally thinking of the logistics of the site visit of when they ask us for that roster.
So what I would do,
residents?
I would put them on the roster and put what level they're at, whether they're at 1, 2, 3, or 4.
Yep.
And I would also make sure that you have their certificates there, because it really shows intent that you are, digging down into the residency program, and you feel that responsibility to inform your residents, because it just shows well.
Yeah, great. Okay, thank you. I appreciate it.
No problem.
I just have one kind of question for the presenters. So, and I just want to clarify it for anybody who's listening. So I know you said during the morning meeting you had a lot of people in the room, like senior administration and everything, but the questions were really just to the task force leads. But I think, would you still recommend having everybody in the room, and do you, like, Baby Friendly would want to still see it senior administration and all your other team members there, correct?
This is Lindsay. Yeah, I would definitely recommend. I think it just shows a lot of support from your hospital, having them there. And they did ask like 1 or 2 questions to our CEO, and I think they geared maybe one question to our WIC representative, just showing that you have community involvement in your task force as well. So I would have them there, whether or not they ask them too many questions or not. Just having them being represented there, I think, is a big deal.
This is Kim. I agree also. Whether they're speaking or not, it just shows support.
Great.
Hey, this is Paula. When we had our site visit in 2015, it was a little uncomfortable because they barely acknowledged senior leadership after all the efforts we had to get them at the table. I hope that practice is going to change.
Yeah. I mean, this is Laura from CHAMPS. I can even mention that to Baby Friendly as something that, is kind of, it feels awkward to the hospitals. Because I think, I think the moral and the lesson is that Baby Friendly wants them at the table. So it is good to make people feel like it's worth their while and worth their time to be at the table. So, yeah, I appreciate your feedback.
Hi. Can I ask a question about the first speaker mentioning the annual skills competencies? Is that a requirement of Baby Friendly that there be an annual for all of your staff, or, what was she alluding to when she mentioned the annual skills competencies?
Hey, it's Lindsay. Yes, during our actual Onsite assessment, I cannot remember our assessor's name, but she was super sweet, and she said she looked at our stuff, and what we do is for the extra 1 hour, we do the 4-hour chance, and then we have a 1-hour skills fair, like check off competency, hands-on thing that we had all of our staff do. And she said, keep this up. She said, every year do this, because you will have to show proof of 1 hour competency for your staff. Now, I don't know if it has to be hands-on. I'm not sure. We haven't really kind of gotten too much into, I think in January we'll kind of figure out what all we need to do to stay compliant for the next few years. But she made it sound like you have to have like 1 year or some type of competency put into place for each staff member from that point forward. So we're just going to, the skills fair was easy. It was a 1 hour. We set up a bunch of times that they could come in and get it done and knock it out. So we're just going to do that twice a year to make sure we get through all of our staff. And also if any new staff members come in throughout like each 6-month period, that'll be the opportunity to go ahead and get them through that training as well. But like I said, I don't know their exact requirements. I don't know if it's a full hour hands-on or if it's like you could do online. I'm not really sure. So you may want to verify that. But she made it seem like you got to have at least 1 hour somehow.
Okay. So that may have been a recommendation by the assessor to make sure that everyone's on top of the skills.
Yes,
rather than a baby-friendly requirement. And the second question
she made it sound like it was a requirement.
Yeah, this is Kim. That's my understanding, too, that you have to have 1 year, every year, you have to have at least an hour of training.
Yes, but not going through all of the skills fair of all of the skills for the length of time that you did originally.
Oh, no, just okay. like a review.
So
okay.
This is Jennifer, and you know that is a requirement, and part of that is to help you so that everybody stays up on the information if there's anything new coming out. So you might want to look as you're continue to collect your monthly data. If you notice anything slipping a little bit, or if you're hearing through any audits that you're doing that there's a particular area that you want to focus in on, then you might pick up on some of those skills, or even, you know, an article that they need to read and then respond to a couple of questions, or put it in annual competencies that are online for your particular unit.
Okay, yes. Okay, thank you. And the second thing was, you were mentioning putting sticky notes on top of, was it on top of slides that you covered things that should not have been in a presentation? Mm-hmm. Or are you talking about in a booklet?
I'm sorry, I missed that question.
I think it was stickers. You'd said that some of the patient education materials had pictures of like bottles with nipples or pacifiers, and you put stickers over them so that, you know, like even when you hand them out to patients, you should hide those images.
Yeah, I think it's that I may be calling it wrong, the Breastfeeding Basics, I think, booklet, and it's a free educational, it's a really awesome book that we were able to get a hold of, and we actually use that for all of our breastfeeding mamas. But they were supposed to be fixing it in the upcoming like editions, but I'm not sure if they have. But the current ones do have a nipple from a pump, like showing a pump, how to pump or whatever, on a couple of pages, and that's what we literally just put a sticker on top of to cover it up, and make sure that the booklet you're handing to show the surveyor, make sure that one is covered up.
Okay, thank you so much.
You're welcome.
All right. Any other questions? All right. Well, I think we'll wrap things up then. So thank you for joining. And our next webinar is going to be on December 11th. Again, it's on the Interprofessional Breastfeeding Education Program that UMMC and CHAMPS is developing. And yeah, again, thank you to our presenters for sharing all of your great experiences and your great pointers for everyone else who's going to be on this journey soon. So thank you and have a good day.